And now I'd like to welcome to our session Dr. Michael Bober. Dr. Bober is a pediatrician and geneticist who directs the skeletal dysplasia program at the Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware. Dr. Bober is a member of the OIF's Medical Advisory Council, and his practice is exclusively focused on the diagnosis and management of children with skeletal dysplasias, including OI. Dr. Bober and his team worked with the OIF to develop the Navigating a New Diagnosis, a toolkit for parents and medical professionals, which is a workbook and tool available for free from the OI Foundation in print or online. And I'll add the link in the chat for the online version. Dr. Bober, please take it away.
Good morning. Excuse me, let me get the slides to come up. Melissa, you can see them okay? The slides are good?
They look great.
Thank you. Again, good morning, everyone. Welcome to the national meeting. Hopefully, this will be our last virtual national meeting and we can get back to being in person for next year. So my job this morning is to help new families navigate a new diagnosis, or perhaps some more experienced families go back and learn a little bit more of the fundamentals and the basics of osteogenesis imperfecta. So, as was just mentioned, there's a whole new set of information that is on the OIF website for families that are navigating a new diagnosis. Here is that link, and when you go to this information page, you can find a number of publications, including the self-same titled book, which can be used as a parent or a medical professional, perhaps, who doesn't have extensive OI experience, to help with a newborn and a new diagnosis. But there are many other things that are on this page. There are fact sheets, there are video resources to help understand what's going on in this book. And I found this to be really important, which is a message from the CEO of the OIF, Tracy Hart, who says, "Congratulations on your new baby and welcome to the OI family." And I know that Tracy sincerely means that, but I think everybody that's involved with the OIF does as well. We want to be able to have this big OI family and have each of the families be a resource for others and overall improve the care for everybody in this big family. Here are a couple examples of the different publications that are also available. An introduction to OI for medical professionals and families, for physical and occupational therapists, for nurses. So anybody that might be involved with the care of a newborn, there are resources that the OIF has created to help with that learning process. So that all being said, what I'd like to do this morning is give you a little bit of a historical perspective on OI and how it was named and how the naming has evolved over time. Certainly for a new family to come in and hear that there could be as many as 20 different types of OI, it can be really confusing. And I think looking back and understanding historically how we've gotten from the name Osteogenesis imperfecta to all of these different types, it helps to make sense. We're going to go through the molecular basis. We're going to talk about how to read your child's genetic reports, a little bit about inheritance and some of the newer forms, and then we'll bring it back and talk about a clinical perspective. So really, our story begins a couple hundred years ago in 1788 with a Swedish surgeon named Dr. Ekman. And Dr. Ekman described a family of 4 generations that had bone fragility, and he called this family osteomalacia congenita. In 1833, Dr. Lobstein wrote a paper about 3 children from a single family that also had fragile bones. And excuse me, but maybe our French interpreter can say this word, but I don't know how to. So regardless, this was what he described in 1833. And in 1849 was the first time we ever heard the word osteogenesis imperfecta. And that came from Dr. Willem Vrolijk in this book, that he was an anatomist and he hand drew pictures of different types of infants with various pathologies. And you see the wormian bones and the large fontanelle and the skeletal deformities, the bowed tibias. And he was the one who coined the term osteogenesis imperfecta. But the reality is the oldest example of osteogenesis imperfecta that we know of goes back several thousands of years, because there is a mummified skeleton that was found in ancient Egypt from the 27th dynasty. And here you can see parts of that skeleton with the significant bowed and deformed femurs and tibias and the large skull. So OI has been around since time immemorial. And we get into the early part of the last century, Dr. Lusser recognized that osteoarthritis idiopathica and osteogenesis imperfecta for congenita were actually the same condition. And Vrolijk and Ekman were actually talking about the same types of individuals. And this is where the very first classification began. He said, well, you can either have fractures that were perinatal or congenital, or you can develop fractures later on in life. And he called that the tarda. Tarda is Latin for late. So you had the early, the birth, or the late. But that didn't last very long. In 1949, there was a Danish researcher, Dr. Seedorf, who recognized that there were some fractures that occurred within the first year and some that occurred later than the first year. And this often helped, or this often was a relationship to how severe a child was affected by OI. And they started subclassifying the tarda type into gravis and levis, whether the fracture was in the first year or after the first year. So by 1949, we're essentially up to 3 types. And 30 years go by, and along comes Dr. David Selence. And the Selence criteria is really the one that is the foundation of the classification scheme that we use today. Dr. Selence is an Australian geneticist. He still, I believe, is practicing, although he every once in a while threatens to retire. He did a lot of his genetic training in Los Angeles with a very famous skeletal dysplasia geneticist, Dr. David Lemoine. And then he went back to Australia, where he published this paper called Genetic Heterogeneity and Osteogenesis Imperfecta. And what he did was he summarized the different types of osteogenesis imperfecta that he saw in his clinic. And he recognized that there were at least 4 distinct syndromes. The largest group of patients showed autosomal dominant inheritance of osteoporosis, leading to fractures and distinctly blue sclera. A large proportion of those adults had deafness or a family history of conductive hearing loss. The second most common group, who comprised the majority of newborns with neonatal fractures, all died before or soon after birth. And these had characteristic broad crumpled femora and beaded ribs in the skeletal x-rays. Autosomal recessive inheritance was likely for some, if not all, of these cases. Now, I'm going to focus on this a little bit more as we go forward, but I want to say here that these children that had this most severe form of OI in 1979 and earlier, when he was making these observations, there was none of the treatment modalities that we have today that were present in NICUs back then. Ventilators, let alone home ventilators, bisphosphonates. There was no sophisticated modern medical care that existed as a potential option for these children. The third group, 2/3 of which had fractures at birth, showed severe progressive deformity of the limbs and spine. The blueness of their sclera appeared less than seen in the first group of patients and could fall into the spectrum of typical. And moreover, the blueness appeared to decrease with age. All patients in this group were sporadic, and the mode of inheritance was not clear, but it was likely to be both dominant and recessive. And the fourth group of patients were essentially a group that was somewhere in between the first group and the third group. Now, our story takes a little twist and goes over to Dr. Victor Mccusick. Now, Dr. Mccusick was a geneticist at Johns Hopkins. Some people say he was the father of modern medical genetics. And Dr. Mccusick turned out to be the journal editor of the paper that Dr. Selence was trying to get his paper published in. And if you know anything about Dr. Mccusick, was that he loved to organize and categorize and give everything numbers. Here you can see this is the Mendelian Inheritance Man. This is a series of books that Dr. Mccusick started that now exists only online, that describes every Mendelian condition in man. So Dr. Selence, you can see, described the groups individually, but Dr. Mccusick came back and said, no. You have to give these different groups numbers. So Dr. Selence went along with that, and hence we have this wacky numeral system where the mild type is type 1, the severe or perinatal lethal type 2 with severe type 3, and the moderate type 4. Which is what I just said here. So this is what became known as the Selence classification scheme. A lot of people, again, wonder why they were numbered in this order, and that had to do with Dr. Mccusick. But the important thing here is that this classification, it's gradual. It goes from one extreme to the other. And it really does define a continuum, a spectrum. And oftentimes in the real world, it can be difficult to tell if an individual has a clinical type 3 or type 4, because maybe they're a little on the line. Or is it a type 1 versus a type 4. There does not have to be nor need to be a super clear-cut black and white type. For most individuals, there is some overlap. Okay, so let's change gears here, given that as we got into the modern era of classification, and switch gears and let's go down a little bit to the genetic level. So as you probably know, we have, according to the Human Genome Project, about 3.1 billion base pairs of DNA. And those base pairs are in this double helix, and they're organized into somewhere between 19,500 and 20,000 well-described genes, which are then organized into chromosomal structures. So there's very much a hierarchy. And when we look at any individual gene of this 20,000 or so, they have a very specific structure. Here you can see the DNAs and the base pairs. They're organized into what we call introns and exons. And the structure of a gene is such that the gene encodes an RNA, which is processed and then becomes a protein according to this molecular code. So 3 base pairs of DNA equals 1 amino acid. And what you'll notice here is that essentially the introns are removed and only the exons are expressed into a protein. So here you can see the first exon is sort of this, rust color. The second one is blue, and then green, and then purple. The introns are removed. The final RNA encodes this protein, and this protein twists up on itself, and you can see how each of the different exons become a different region in this protein. And this is essentially how all 20,000 of the genes work. So this is a similar cartoon. This talks about the upstream region. There's exon 1, there's intron 1, exon 2, and then the other downstream region. And we give everything addresses. And the address starts with the first DNA base pair in exon 1. We call that a C dot. So this is C dot position 1. And this exon here, well, it turns out that it's 35 amino acids long, and you get to C dot 36. And then the convention is that we don't keep numbering the introns, but we put a plus until we get close to the end when we put a minus. And here it starts again at 37 and goes up to 72. So when you look at a genetics report, what you see is the name of the gene. You see the location, C.1799. That means at position 1799, something happened. What happened? Well, there was supposed to be a T, and it was changed to an A. This is the DNA address of the molecular change. What does that do to the protein? Well, it's a protein, so we give it a P. That's a P dot. And then in this case, it changed a valine to a different amino acid. And it's in position 600 of the protein. So we'll come back to this, but this is the mechanism or the process by which we name and give DNA its location. So now we're back to 1983. So we're about 4 years after Dr. David Selence published his paper that classified OI into those 4 clinical types. And we had the very first identification of a mutation in a patient that had osteogenesis imperfecta. And it turns out that it was in collagen 1. And that identified collagen 1 as a huge target for learning about osteogenesis imperfecta. And what we learned is that, well, there were actually 2 genes, a collagen 1 alpha 1 chain and a collagen 1 alpha 2 chain, that come together to make a collagen 1 protein. And here you can see the collagen 1 alpha 1 gene, which is in a cartoon up here. These little black marks are the exons. It's on chromosome 17. It has 51 exons. It is 18,000 base pairs long and makes a protein that is 1,464 amino acids. And the collagen 1 alpha 2 chain is on chromosome 7. It's 52 exons long. It actually is 36,000 base pairs long and creates a protein of 1,366 amino acids. And the primary structure of collagen 1 protein is such that every 3rd position is a glycine amino acid. The reason that that's important is because glycine is the smallest amino acid and it allows the protein to rotate and twist on itself. Most often, but not exclusively, the first position is a proline and the second position after the glycine is a hydroxyproline. And you can see the black dot represents the glycine and the next amino acids are XY. And what happens is that 2 alpha 1 chain and 1 alpha 2 chain create this braid. They twist themselves up. The front edge and the back edge get removed. And you have this very nice long braid that becomes a critical part of bone structure. And we know now that mutations in both the alpha 1 and alpha 2 chains cause osteogenesis imperfecta. We know that these particular mutations on it, that they're passed on. We know that if you look back at Dr. Selence's classification scheme, mutations in collagen 1, alpha 1 or alpha 2 were detected in all 4 types. And at that point, we sort of changed our thinking. Previously, we thought that each of the different types was going to be caused by a different gene. Well, we changed that thinking to the idea that, okay, all of OI was caused by collagen 1, and it was the location, it was that C dot position of the mutation that was going to be responsible for the different types. And this was the working hypothesis. Here you can see we're up to 1991. This is a review article from Dr. Byers, who is part of the OI Foundation group, where the 4 different types are described based on what types of mutations have been described. I just want to point this out kind of quickly, but I think it's important to know that when you do meet with a genetic counselor or geneticist, they're often going to want to draw a family tree. So in the convention is that males are square, females are round, unknown sex is a square turned on its side. We usually put an arrow to point to the person that's seeking medical attention, and we color in the people that have the condition that we're discussing in this particular family. So this is what dominant means. Dominant means the phenotype appears in every generation, with each affected person having an affected parent. If a child, any pregnancy, there's a 50% risk of inheriting the trait. If you don't have it, you can't pass it on, and the number of males is equal to the number of females. So here you can see a dad, one of two sons and one of two daughters, each has this dominant condition. For practical purposes, think OI. Recessive, typically only siblings are affected. The recurrence risk for each sibling is 1 in 4. And there can be an increased risk if the parents are from the same genetic background, whether that be a small isolated town or village, or perhaps even some, some type of relative. And that's what this shows, where we have cousins who have a child. This is recessive. Okay, so we're going to switch gears again. This is not a management talk, but please remember, calcium is important. So this sort of brings us into the modern era. So this is a paper that came in 2000. So we're finally into this century here. Dr. Gloria's group out of Montreal with Dr. Rausch published 7 patients from 7 families, which appeared to have a dominant inheritance pattern of a type of OI that was sort of a moderate type, but there was something different about their skeletons. You can see that they had this dense metaphyseal band, but also 4 out of 7, more often than not, when these individuals broke, they developed what we call a hyperplastic callus. Their scab, if you will, to heal the fracture was exuberant, and it was large, and it was much, much more than we expect it to be, and more than what's seen in other types of OI. Not very long after, again, Dr. Glorio and his group described an additional family, again with a moderate phenotype, that appeared to be recessive. And they pulled this out of their group of families really by looking at and studying their bone biopsies. This is in 2002. So now all of a sudden we've gone from 4 types. It took 20 years or more to go from 4 types, but all of a sudden in the beginning of the 2000s, now we have type 5 and type 6. And wait, hold your hat. Here comes type 7. 8 patients from 1 family, again in 2002. So now we're up to type 7. And now as this is going on, there's a little bit of controversy in the community where a lot of us were focused or using Dr. Selence's criteria and thinking about it clinically, where now all of a sudden, every time we're finding genes and there's a different gene, there becomes a different type. So this was the pedigree. You can see this looks like a large recessive pedigree from a smaller First Nations community in Quebec, where this type 7 was described. Well, this matches almost identically the pedigree that was in Dr. Selence's paper from 1979. So right away here, you have a set of facts that becomes interpreted by two different, there are two different interpretations for the same set of facts. And this is where some of the split in how to think about types of OI came about. A couple years more go by, now we're up into 2006, and here is another gene that's found, CRTAP. And then shortly thereafter, it was recognized that these three genes, LEPR1, CRTAP, and PPIB, together form a protein complex. And this complex hooks on hydroxyproline at one very precise location, position 986 on this collagen protein. And here's the third gene in 2007, 2009. And now all of a sudden what happened was we looked up and we had types 1 through 4, which were always sort of supposed to be clinical types, reserved, if you will, for only mutations in collagen alpha 1 or alpha 2. There was the hyperplastic callus type 5, which was subsequently identified to be caused by this IFID-M5 gene. This was the type 6 family, and then we have these 3 additional genes, which even though they work in the exact same protein, each got its own type, 7, 8, and 9. But wait, we just keep going, and now there's type 10 and type 11 and type 12. And when I made this slide, there were 15 types. I believe now we're up closer to 20. So the remarkable point of this type of classification scheme is that the new forms of OI are not anymore defined according to their clinical severity, but according to the molecular basis. So do we want to classify OI clinically, or do we want to classify OI based on the molecular basis? And that was really noticeable. It was a big controversy going back around 10 years ago. In recent years, some authors have proposed an expanded Selence criteria with each causative gene receiving its own number. However, as the original classification scheme always included recessive forms, there's a proposal for a simplified and clinically friendly approach by decoupling the Selence classification from the causative gene and only adding type 5 because it is clinically distinguishable. So with that, let's take a sip of coffee and move on to the next section. With all this historical background in mind, let's sort of ask almost a rhetorical question: what is OI? And believe it or not, there is not a single well-recognized uniform definition of OI. But this is the one that I think probably a prize. It is a genetic disorder causing skeletal fragility which ranges from in utero death from multiple fractures to an average lifespan with osteoporosis, fractures, and other extraskeletal manifestations. This is an interesting figure from a paper that looks at x-rays of individuals with OI. On the left side of this panel is someone that is really indistinguishable from typical, but has OI. Here you can see, we start to see some scoliosis. We start to see maybe a smidge of bowing in the femurs, shorter stature. To be honest, I'm not sure what the story is with this exact panel, but presumably this has more short stature. Scoliosis, you can start to see rods, extreme short stature, scoliosis, deformity. So all of these people have OI. And you can imagine that when you see somebody in the clinic, especially for just one visit, it can be very difficult to know exactly where that person lives in this spectrum. It is a continuum, it is a spectrum, and it's based on primarily a propensity to fracture and how those fractures heal. Being classified is useful. It's useful as a family because it helps you understand what the prognosis is. What do we expect for somebody that has a similar skeleton to your child? It's important because we can identify the mode of transmission. Are you as a family still in the baby game? Do you want another child? Understanding the mode of transmission is important, and we do use this information to help guide treatment. However, molecular diagnosis is not necessary to initiate treatment. And we still to this day have a very imprecise association with genotype, that is the genetic change, and phenotype, what the person looks like. Despite what some people may have told you and what you might read in a genetics report, having the mutation and having that genetics report is not a crystal ball. It does not tell you what your child's future will be. If a mutation is present and you think that your child clinically has OI, that mutation tells you with 100% certainty, yes, OI is present, but it does not give you the type. So we've talked about skeletal fragility and short stature. What are some of the non-skeletal things? Well, the teeth can be involved, and that's called dentinogenesis imperfecta. There can be laxity and loose joints throughout. The sclera can have a bluish hue. Sometimes glaucoma can be seen in older individuals. We can see hernias and easy bruising, at times hearing loss, as well as cardiovascular concerns. These are a couple of x-rays which sort of span the spectrum of what we see or what we can see. Here is a skull. Some of you may be familiar with the term Wormian bones. Now, these are multiple islands of bones that are along the suture lines in the skull. They are not fractures. They really have no functional significance, but they can be useful in making a diagnosis. And no, they're not called Wormian bones because these lines look like little worms. They are called Wormian bones actually because they were initially described by Dr. Wormius. And here you can see a very severe skull where it's very hard to make out the mineralization at all. So sort of a mild, moderate, and severe OI spectrum. Here you can see the same sort of a spectrum when we talk about chest walls. These bones are a little gracile, a little thin, but generally have a good structure. Here you can see the rib cage becomes a little bit more wavy. There's a little bit more deformation. You can see some fractures spread out here, and to a more severe chest where there are multiple fractures, and we sort of have this Christmas tree or bell-shaped chest. We look at spines. This is a spine that has a little bit of flattening, but really overall pretty good. And then as you get more into moderate OI, you can see flattening and definitive fractures here, and fractures in the back, as well as osteoporosis pretty significantly here. The spectrum of what a femur can look like, from relatively normal, some osteoporosis with a healing fracture with a little bit of a bow. As extremities become more affected, the bone becomes shorter, and also you can see how the bone is wide and then narrows, and then in the more severe forms, it doesn't narrow very well, and the edges are almost parallel, and then we call this sort of accordion, as if it was collapsing on itself. So Dr. Selence, who a lot of us still look to as a leader here, in 2014, so not that long ago, went back and sort of redid his clinical diagnosis, nomenclature, and severity in the context of all the controversy that was going on. And one of the things he did was he took us through OI at various stages of diagnosis. Because remember, back in 1979, there were no prenatal ultrasounds. So here we start to see, well, what do we see in our 20-week ultrasound findings? Well, in type 1, or the mild OI, really don't see much of anything at the 20-week ultrasound, although every once in a while you can, in fact, see a fracture. In the moderate forms, rarely fetal long bone fractures are bowing, but they may get more noticeable in the last trimester. In the type 3 OIs at 20 weeks, there is shortening of the long bone seen. There are fractures and bowing of the long bones. The ribs with you may see rib fractures and decreased mineralization. Now, in the more severe, in the severest forms of OI, these ultrasounds show shortening of the long bones, much the same. Fractures with this sort of undermodeling, this lack of narrowing, and this crumpled concertina or accordion shape that we described, rib fractures and decreased mineralization. The difference between these types is exceedingly difficult to make off of a 20-week ultrasound. But nevertheless, I know that this happens all the time, because we get calls from families after a 20-week ultrasound where features like this are seen, and the families are told that their child has a lethal form of OI. Much like this family and this little girl here, who I believe is about 1.5 years old in this picture, clearly without a lethal form of OI. Talk about fracture rates and pain in here. Type 1 OI, we're talking about essentially a fracture a year, no significant bone pain, don't miss time at school. As we get into the more moderate we're talking about more than one fracture a year, a big range, but maybe around 3, with perhaps a week of school missed with pain or fatigue. And as we get into the severe OI, we're talking about more than 3 fractures a year, chronic bone pain, which is often treated with bisphosphonates, and school attendance is definitely compromised by fractures and fatigue or pain. So this is what Dr. Selence proposed as a revised criteria, where he had type 1, type 2, type 3, but rather, instead of pulling all the individual genes out into their own type, he put each gene into the type that it was observed in. So type 1 was only collagen 1. Type 2, the perinatal lethal, could be collagen 1, or it could be CR-TAP, or it could be LEPR1, or it could be PPIB. Here are the multiple genes and inheritance patterns that could potentially cause type 3. Here's our type 4s and our type 5s. So does this person have type 8 OI or type 4 OI caused by LEPR1 mutations? Because these two terminologies sort of say the same thing. They both tell you which gene, but only when you say type 4 caused by LEPR1 do you have an idea about what the clinical presentation of that patient could be. So switching gears again, genetic testing. So DNA can come from many different types of samples: blood, saliva, skin, amniocytes, which are skin cells that are shed in utero by a baby. DNA is extracted, it's amplified or replicated, and then it can be sequenced and we get a report. So this is a report that came from one of our patients in our clinic. And you can see that here's the name of the gene, collagen 1, alpha 2, in exon 27, they found a mutation. Where? Well, the C dot gives you the address of the DNA. So that means at position 1711, there was a G that was changed inappropriately to an A. And the change in the DNA led to a change in the protein from a glycine to an arginine at this position 571. Now, remember, the glycine was that smallest amino acid that everything twisted around. So this mutation means that this person's alpha 2 chain cannot braid up in the typical way. Inside the written report, there should be some information about this change that the lab looked up from various sources and talks about. So this change has been previously reported as a pathogenic variant associated with OI. So this is a very good and well-written report because it just says it's associated with OI. Some reports say this has previously been described as causing, let's say, severe OI. That does not mean that your child will have severe OI. It means that somebody wrote in a book and published that this mutation in a family that they saw caused severe OI. It doesn't necessarily mean that the new child who was tested will have to have severe OI. This is another report, similarly written, right? Here's the collagen 1, alpha 2, here's the C dot information, here's the P dot information. And here it says, it has not previously been published. Okay. So this is another comment we see all the time. Remember how big I told you that these genes were? They were thousands of base pairs long. People with OI rarely, outside of the same family, have the exact same spelling change, the exact same mutation. So it's not uncommon for the patient in front of you to have a mutation which has not been described before. And as I'm trying to hint at, that doesn't matter in the sense that it doesn't tell you the clinical type, even if it was described before. Your child in front of us, your child's x-rays, the clinical course, all of these things are what gives us the information about what clinical form of OI the patient has. Now, this database is a little out of use, but it does tell you here that there's more than 1,600 unique mutations that have been described in the 2 collagen 1 genes. There you see some ligamentous laxity, so I'll say thank you. Please, if you're interested, I'll refer you to the Rare Disease Network and this registry, which is actively studying individuals with OI. And a big shout out and thank you to our OI team. I believe Dr. Cruz and Dr. Franzone are listening, but also to Tina McGreal and Mary Ellen Little. So thank you, and I will happy to stay and discuss and answer questions and whatever is appropriate.
Great, thank you so much, Dr. Bober. We do have a couple questions that have been submitted ahead of time, but if you have any questions for Dr. Bober, please feel free to write them in the chat, and we will ask them for you. So to start, I think there's a lot of questions about some of the more ultra rare forms of OI, including type 14. If there's new research fronts to the ultra rare forms, and any perspectives and treatments. I think kind of specifically, what steps should people take if they have an ultra rare form of OI and there's no local OI providers near them? If they're not lucky enough to, live on the East Coast to be near you guys, what are your take on that? Like, what would you say?
So I think one of the points that I was trying to get across was that at this point, there is no real fundamental care difference based on the molecular testing. So whether you, as a family, have an ultra rare mutation or an ultra rare gene or a common one, the child that we see is going to be treated really by the standard means. We're going to use the same modalities. Dr. Franzone is going to put a cast on the exact same way. We're going to approach the child with similar, nutrition things. We want to make sure that they get enough calcium in their diet. We want to make sure their vitamin D level is good. We want to make sure that they're moving and getting therapies as much as tolerated and what is age appropriate. Some children, based on how involved they are, might qualify to get some bisphosphonate therapy. So we're really going to treat that child based on what we see in front of us. We're not going to use the genetic test result as a blueprint, as a guide to either say, this is what's going to happen to this child, or this is how we should manage this child. Maybe down the line, more information comes along, and it would suggest that, individuals with this particular change might benefit from, therapy X instead of the standard one. But that doesn't exist today. So I think it's really hard, as somebody who specializes in rare diseases. I think if you have a child with a rare disease, it is probably worth trying to come into contact with an experienced provider. I think most people that do what I do partner with local doctors all the time. We would be not overwhelmed. And, you can't have somebody traveling 500 miles when there's, an acute problem. But what you can do is establish a core group of local providers who you know and who you trust, and have some experts that you can use to help guide the local care and help interact with the local care providers to provide the family and the care providers the best guidance. And there are a fair number of experienced, based on the age and what the problems are, but there's a fair number of experienced OI providers that would be happy to help in that capacity.
Absolutely. And, we at the OI Foundation are here to help direct that. So if you want to be put in touch with one of our medical experts, we are happy to do that. You can reach out to our health educator, Jessica Ransom. We'll put her contact information in the chat, and she can help get you in touch with people. Thank you. Another question we have is, if my child has OI, what is the probability that her child would have OI in the future? And I know that might be hard depending on the dominant or recessive forms, but is there kind of just a general way to determine that?
No. To answer the question with the best precision, that's where the genetic test is important. So there's a couple of things. If the mutation is in the collagen 1, alpha 1 or alpha 2 gene, it's presumed to be dominant. So you would then have to ask the question, well, does mom or dad actually have OI? And there's a situation that occurs that we call gonadal mosaicism, which means that mom or dad may not have OI in their skeleton, but they may have OI in their gonadal tissue, which has nothing to do with their health. But if it's in those tissues, then they can go back and use the tissue use the sperm or egg that has this change that exists in it. So a new dominant, there's a recurrence risk of 2 or 3% from this gonadal mosaic. I know that was fast and complicated. I would guide you back to your local genetic counselor to talk in detail about that. Recessive OI, it's going to be 1 in 4 with the same partner.
Great. Switching to treatment options. Do bisphosphonate treatments work differently depending on the gene that's affected?
There's not definitive data to suggest that. There's some hints that maybe it doesn't work as well in 1 or 2 of the subgroups, but that's the drug of choice at this moment in the pediatric setting.
Great. And would somebody with a severe type of OI benefit from a low dose of bisphosphonate?
That's tricky because, again, we would want to know the age of that child or the age of that person and what previous dose they might have been on. Mm-hmm. So usually with severe OI, We like to use Dr. Glorio's protocol that was published in 1998 in the New England Journal of Medicine. And most of us would call that sort of the standard dose. As time has gone on, I think most centers, after 3, 4, 5 years of the standard dose, do go down on the dose of bisphosphonate, with the idea that the child should continue to be treated until the end of their linear growth and growth plate closure. So it would depend where in that process did the child get the first couple of years of standard dose. But yes, a low dose could have benefits for a person with severe OI.
Great. And Dr. Gloria is actually with us today. He's in the chat, suggesting that he's reiterating what you're saying, to focus more on clinical severity rather than a specific number, especially when.
Thank you. Hi, Dr. Gloria.
So switching topics slightly from the diagnosis and early treatment to general handling, do you have any suggestions for proper ways of changing a diaper to prevent injury, promote safe transition from crawling, and minimizing breaks?
So at least in terms of handling an infant, number one, I would refer you back to those pamphlets and brochures that I highlighted in the very beginning. They're already on the OIF website. They're very well established. They have great pictures. That being said, the whole idea, the fundamental idea around handling a child, an infant with brittle bones and severe OI, is that we don't provide, or we don't expose their skeleton to forces over a small area. Translating that, meaning we never want to use pincer grasp. So, a typical child, you're changing their diaper, what do? You probably grab their ankle with your fingers and you lift their butt up and you lift their leg up. That is not the way to approach an OI situation, right? We don't want focused pincer grasp. We want to use our palm. We want to spread that force over the largest surface area possible. So to change a diaper in a child with OI, you want to take your whole hand and sort of slide it under the lumbar spine, the sacrum, the butt, and lift up gently, carefully, slide that diaper off, slide the new one in, put the child down. So all of the handling is essentially goes back to that same principle. We want to spread the force out over the largest possible surface area. And if you can sort of keep that in mind, that's what you can do to minimize fractures. But look, let's be realistic. If you have an infant with severe OI and they're newborn and we haven't had an opportunity to get much pomidronate or other bisphosphonates on board, and we're just getting started, and things are going to break. And it doesn't mean somebody's a bad parent or they necessarily even did something the wrong way. This can happen, and I think what we definitely don't want to see is we don't want to see fractures interfere with bonding. If we don't want you to be afraid of your baby. We want you to bond with your baby. I can pretty much guarantee that in a severe infant, at one time, a parent's going to break a bone. And I can pretty much guarantee you that it is never intentional. So we just need to move a little beyond that, and we do the best that we can every day. Unfortunately, we have children in our NICU and we have to draw blood, or we have to do this or that. And, we may break a bone too. It's okay. Fractures heal. As Dr. Cruz loves to say, fractures heal, emotions don't. So please bond with your child. We can take care of fractures. We can take care of pain. We can make all of those things minimal. But we need folks to bond with their kids.
Absolutely. And what's your take on things like tummy time and those kind of things that, I know people struggle with?
That because of OI being such a spectrum, both in severity and the potential ages of children that we're talking about now, it's almost an impossible question to answer, not specifically. But broadly speaking, for somebody who would tolerate tummy time and who's capable of it, whose skeleton is capable of it, we would absolutely support it.
Great. So we have a question actually from Dr. Glorio. What about extraskeletal abnormalities like pulmonary complications and such that might affect lifespan? I think people focus on babies breaking bones, but are there other things that we need to focus on?
Thank you, Dr. Glorio. That's a great question and something that I love to talk about. So this is really, I think, to a large extent, where sort of the rubber meets the road. And now we're talking about the birth of children with severe OI. Maybe in 1975, they would have been called perinatal lethal. But today, I think we can just say they have very severe OI. And, in the newborn period, fractures don't even matter. We don't take x-rays. We almost don't even count them. The only thing we care about, honestly, is how is the child breathing. And these are some very important conversations that need to be had with families prior to birth about what their wishes for their child are and what kinds of medical interventions look like to them. So when children have respiratory compromise, it tends not to be from the lungs per se, but from the rib cage and fractures in the rib cage and the growth of the bones in the rib cage. Minimal intervention would just be the standard flow of oxygen through a nasal cannula. Now we have different types of tools to provide not necessarily oxygen, but higher levels of air flow, which help to inflate the lungs and move air in and out. And those types of flow can be given also by nasal cannula, sometimes by a nasal mask, a nasal trumpet, or sometimes by a face mask. As we escalate, some of the most severely affected children might need to have a breathing tube, intubation. And, sometimes it comes and goes. For example, if you have a baby who may only have moderate OI, but if they have a pneumonia, which can happen during birth, they might need something more significant to get them over the pneumonia. But there are some children who require long-term respiratory support, and then that could potentially look like a tracheostomy and a ventilator. So it's really important to recognize that we have all these tools now. Babies go home with tracheostomies on ventilators. That did not happen in 1979. So it's really important for somebody who's perhaps diagnosed with OI at 20 weeks, the standard thing that is taught to our maternal fetal medicine colleagues in their training is if you see fractures at 20 weeks, it has to be lethal. And I'm here to tell you it doesn't. But what that looks like needs to have a lot of nuanced discussion. Nothing is absolute. I hope that sort of helps.
Well, thank you so much. We've had a couple other questions come in. However, we are at our time.
Really fast, yes. Slower gross motor development is common. Bisphosphonates do not stop fractures. They help to decrease their frequency. So having a fracture in the middle of a bisphosphonate infusion is not unusual. Sorry, I snuck them in.
No, perfect. That's great. Thank you, Dr. Bober, for your time today. Thank you, everyone, for joining us. We're just starting our day full of sessions. We have our research update coming up next. We had a question that came in privately to me about stem cell research. We'll try to get to that one in the research update. We also have 2 back-to-back sessions of Ask the Expert. We'll cover genetics, we'll cover surgery, women's health, mild OI. So please check those out if anyone, if you have further questions. And of course, you can always reach out to our health educator, Jessica Ransom. We have her information in the chat. She can put you in touch with Dr. Bober or any of our other experts. So thank you, Dr. Bober.